Okay, folks, are we all ready to go? On the principle that the most important people are here already, I think we start. Can you hear me at the back? Yeah. All right. Okay. John. What's there? Oh, there's a dual. All right. Okay, good morning. My name is Arthur Hayward. I'm going to talk to you about information for action. Have a little bit of Monday morning action. We're going to start with talking about some general principles of goals, targets, and indicators. And then we're going to look at some specifics of using information to generate some decisions. John? One basic thing that we often forget, especially those of us sitting at national level offices and international organizations, is that all information comes from the bottom. There is lots of information that is generated from clients at community level and health centers and facilities. As we get higher and higher up the chain, up this pyramid, we don't generate any information ourselves. I see Ciaro nodding her head here. You don't generate any information yourself. You are parasites. You parasite other people's information, and it all comes from the community. The people who collect information are the ones at the facility level, and we have a huge tendency to forget about them as we sit in our air-conditioned offices. And we load them with huge amounts of information, most of which they don't use themselves. The most common feeling is people are collecting information for someone else at a higher level. Yeah? Next one. That's a basic HISP principle. Next thing is to put all you computer nerds a little bit into your place. Computer are very important in a health information system, but they are a very small part of the overall cycle. There has to be a decision. What is happening here in this room over the last few weeks and this coming week is decisions are being made. Countries are deciding, we want to improve our health information system. All right? You have to decide what you have to decide what decisions you're able to make as a country, and we're now starting this process of what information that are we going to collect, what is our org unit structure going to be, what data collection forms are we going to collect, what computer systems are we going to use to process this data, etc. But that's all on the basis of what decisions can the country make. Is it a decentralized system? Is it a centralized system? What can your country, the 13, 17 countries here, do about improving information system? And that's about processing. This is where the computer is really useful. We then, with our computers, we produce graphs so that people can analyze the data. There has to be a process of analysis of data using indicators, which we're going to talk about in a few minutes. Those indicators are then presented and communicated to the various levels, from the Minister of Health right down to the community health workers and the people in the community. We have a process of interpretation, and then we come back and we start the cycle again. And hopefully the cycle doesn't come back to exactly the same place. It's moved on a little bit. We've now got a system that is working. We've got some indicators. Which are the best indicators for us? Which are the most useful ones? And the cycle starts again, moving on. Okay, so computers are useful, but they're a small part of the overall using information for action process. Now, the slide has beaten me, but how many of you have ever heard of the Millennium Development Goals? All right, most of your hands go up, huh? I'm sure all of your countries here signed in 2000 to improve the situation of the world. Everybody said by 2015, that's next year, by the way, the world is going to be a better place. There's going to be no more poverty. Everybody is going to be educated. Women are going to be equal to men. Health, we're going to have no more illness. The environment is going to be clean in spite of America, and the world is going to work together in spite of the 200 wars that are going on around the globe. John? So, how do you measure these things? How do you wake up in the morning and say, all right, I'm going to measure how the world is improving? We set the first goal, they set the first goal, which is to eradicate, huh? Notice that. There's going to be no more extreme poverty, and nobody is going to go hungry in the morning. Everybody's going to have a breakfast like we've just had this morning. You didn't have breakfast, that's your fault. Okay. So how do you measure eliminating poverty and hunger from the world? We in health have got a very small part to play, and we've got indicator number 4, which is the prevalence of underweight children under the age of 5 years. Huh? That's the one thing we can do. There are 101 different ways that you can measure this. Some countries use stunting, some countries use wasting, but the global measure, what everybody should be measuring is, what do we measure underweight for age? What are we measuring? We're measuring the child's weight and its age. And there's that Road to Health chart that all children should be following. Yeah? So it's underweight children before the age of 5. That's what we are measuring. That's our indicator. Good, John?
Just 1 second.
Yeah.
There are some countries who are making the national core indicators, for example, and including this, how Willard is including this one into the HMIS protein system as one of the indicators.
Yeah, I mean, are you asking them a question? I mean, basically, you need 2 data elements here. The weight and the age. Huh? And you need the percentage of children that are below a certain line on that Road to Health chart. And that, I mean, as far as I'm concerned, it's obligatory. If your national health information system is not measuring this, then you should get the North Korea treatment. All right.
Even water want to listen to other.
All right. It'll be improving my computer a little bit. Maybe it'll wash those. Okay. The 4th goal. I'm not going to deal with the equality of women or education or the environment, which are goals 2, 3, and 4. I mean 2 and 3. But 4th goal is reduce child mortality. And here the aim, we're not going to eradicate children dying. We're going to what? we're going to reduce by 2/3. So only 1/3 of the children will die that were dying in 1990. Children under 5. All right. Under 5 mortality is a very crucial indicator of overall development. In fact, we in health have got very little to do with reducing under 5 mortality. Why? What do we do for health? In health, nothing. Why do children die? They die of poverty, they die of poor sanitation, they die of a bad environment, lack of access to proper food. That's the majority of children die. Health, we do save maybe 10%, but we are able to measure it through the under 5 mortality rate. Infant mortality rate is what? What do we classify as infant mortality? Somebody at the back there. What is an infant? Do you have an infant? What's the age of an infant? Under 1 year. Okay, under 1 year is an infant. So we're measuring under 5, and then a separate category is under 1. We're also measuring measles. Again, we give 6 different vaccines to children, or some countries give 8 vaccines to children. We've chosen, or the world has chosen 1. Why? Because it's easy to measure, and if you have received measles, we are assuming that you have received DPT, polio, BCG, and all the other ones. All right? So we're measuring 1 vaccine as an indicator of a much larger set of activities to protect children. All right, maternal health. Who can remember how much we were going to reduce child mortality by? 2/3, What are we going to do for maternal mortality? 75%, 3/4, yeah? This is a very, very ambitious target because maternal mortality is rooted in traditions and cultures, and it's very difficult to get, especially men, to get their wives to go for safe delivery. So, but we're going to measure it, and the world has said, I don't know, you can tell me maybe, but very few countries, I think, are going to achieve this, reducing by 3/4. Maternal mortality ratio. That is, of all the women who get pregnant, how many die? Of all the children that are born alive, how many women die? And that's why it's a ratio. I'm not going to go into the epidemiology. The world has also decided that the best way to measure whether women are getting good care is by providing skilled birth attendants. Yeah? And a skilled birth attendant is a person who has been trained as a nurse or a doctor and then hopefully received some specialist training in midwifery. A lot of our countries cheat, and they pretend that just because you're delivering in a facility, I see you laughing there, because you deliver in a facility, you are delivered by a skilled birth attendant. In the country where I live, Tanzania, most women who deliver in a facility, they get delivered by the sweeper or the watchman, not by skilled birth attendants. So we cheat and we say that there are skilled birth attendants, but there's a very clear definition that the WHO is trying to enforce about what a skilled birth attendant is. We're not going to go into the details, but these are the kind of issues that we have to measure, and when we're setting up an information system, we have to deal with it. Contraceptive prevalence rate. What's the best way to stop a woman from dying in pregnancy? Stop her from getting pregnant. Yeah? So if women are not getting pregnant, they're not going to die in pregnancy. So this is an obvious one. I've actually moved this. You'll see it's number 19C. I've moved it from HIV/AIDS up to, I don't know what it's got to do with HIV/AIDS, but I think it's much more relevant to put it here rather than put it under HIV/AIDS, because most contraceptives don't protect you against HIV. Okay. No, go. Okay, that brings us on to the next Millennium Development Goal, which is to combat HIV/AIDS, malaria, and other diseases. The other diseases is tuberculosis. There are 3 diseases that the world has focused on for the last 15 years: HIV, malaria, and tuberculosis. Yeah. Okay, so what is our target for HIV/AIDS? We're not going to reduce it by 3/4. That's just not possible. We are going to halt the spread and hopefully reduce the spread. So what we had in the 90s was a really steep rise of HIV in most of the world. What we're hoping to do now is that it will flatten off, and in some countries, the number of HIV patients will actually start to reduce by stopping new infections. Okay? So what the world did was they said, right, how do we measure new infections in a disease like HIV? Very, very difficult, because HIV is a lifelong disease. The closest we can get is to say, all right, in young women, 15 to 24 years of age, what is the rate of infection? Because very few people get infected before the age of 15, and that's the way we can tell. Why did we choose pregnant women? Because most women come to antenatal care and they are already victims, they're already giving blood, so we might as well take 1 more cc and test their HIV status. All right? So this is how we can measure the spread of HIV. The other thing that the world mistakenly thought was going to reduce the spread of HIV was condom use. We are trying to measure condom use. Okay. Condom use is an extremely difficult thing to measure. You have to go into people's waste paper baskets in the morning and see whether they've actually used the condoms. But what we can do as a health is how many condoms have been distributed, and we hope that most of those have actually been used. So we can measure the distribution rate in our routine service. Through surveys, we can do condom use at last high-risk sex and how many people know about ways of preventing AIDS, but that's not something that we deal with at all in the HMIS. John? All right. The other diseases, this looks like a kind of a death thing. Malaria and TB, death rates and use of effective measures against malaria, and death rates, prevalence, and treatment of tuberculosis. All right? So we can measure the prevalence of TB and malaria. We can measure how many of those TB patients have been treated. And I'm sure that in the next round of whatever the Millennium Development Goals are going to be called after 2015, we'll start to include the treatment of malaria. Because in 2000, when these were done, that we didn't have effective treatment against malaria. The whole world was going resistant to malaria, so they didn't measure the treatment of malaria. Now, 15 years later, we have an effective treatment for malaria, and we can start to measure it. I'm sure we'll measure it. Millennium Development Goal 8 is a bit of a hodgepodge. I mean, if you look at this indicator, the proportion of population with access to affordable, essential drugs on a sustainable basis. Even the people in WHO, with all due respect, have got this thing completely botched. They've tried to put 4 indicators into one indicator, and they've got a mishmash that nobody can possibly measure. So this is an impossible indicator to measure. I'm not even going to deal with it. All right. So what we've got at national level, remember, that's at the very tip, at the apex of that pyramid, is a set of 16 health-related indicators, all of which obligatorily have to be in your health information systems. Otherwise, you're not part of the world community. So when you're designing your health information systems, remember these and make sure that they are there. Underweight rate of children, infant mortality rate, under 5 mortality rate. Ooh, I've left out measles. Oh no, the measles is there, down. Measles is down. Maternal mortality rate, HIV prevalence in 15 to 24-year-old women, malaria and TB prevalence, death and cure rates, and family planning I've left out. Births attended by skilled midwives and availability of essential drugs. Okay. Any questions? That's the first part over. John.
Out of this one, which one can be collected from the routine HMIs?
All of these.
Routine HMIs.
All of these should be collected by the routine HMIS.
Infant mortality rate, maternal mortality ratio.
Yeah, well, yeah, of course you can. You can, I mean, all right. He's being difficult, huh? Because he knows he knows he can. If we go back to that first slide, go back to the pyramid, John. Yeah. Okay. The vast majority of everything that we're trying to measure occurs here in the community. Most children die in the community. Most women who die in childbirth die in the community. Most people with malaria, most people with TB, most people, they die. They're clever. They know we can't do a damn thing at our health services. So they prefer to go and die in dignity in their home. Where we can measure is there. We can actually measure at facility level. So the limitation of our data from the routine HMIS is the fact that we are up at that second level. But it's still very useful to know of all the children who are admitted to hospital, how many die. So we can get a institutional infant mortality rate. We can get an institutional under 5 mortality rate. We can get an institutional maternal mortality ratio. We can get an institutional TB death rate. We can get it. So that is the limitation. We cannot, nothing that we get from the facility, no HMIS in the world is 100% accurate. But it is a whole lot better to have people involved at facility level measuring malaria death rates and TB death rates and immunization of children than to leave it to get up to this level here where nobody has ever been known to take any action ever. You can't take action up at this level here. This is where action takes place, and this is where we measure it. So it has to be in our facility information system, those 16 health-related indicators. Because all of you who work at national level, you know you don't do anything. You go to meetings and you talk. Yeah, I see some smiles coming out. At international level, it's even worse. More talk and less meetings. Yes.
I have some question. Please go back to the cycle.
The cycle, yeah. You can go down to the cycle. Okay, go.
Yeah, my side is not so good for this one.
Presentation and communication.
Yeah, presentation, communication, and interpretation. Which one is before or after? Maybe this is before interpretation, or I'm still not clear about this one.
Yeah, you know, there's no perfect cycle, huh? I mean, my feeling is, that you need to put the data in the form of graphs. You use all the fancy tools that you've got in DHIS, the data visualizer and the dashboard and that kind of stuff, and you disseminate it to people so that a maternal and child health coordinator can have a graph on her computer and can then interpret it. You could say that analysis and interpretation go together. You can, you're right. It depends, but for me, the important thing is to use the facilities of the DHIS to present the data, get it out to everyone, so that everybody from the facility HIV/AIDS coordinator to the facility TB manager has got the data, and then he can interpret it for his little bit. He can't interpret it until he's had that communication. Yeah, I mean, you can argue it both ways, huh? Yes, yeah? Yeah.
Hello. So I'd like to continue the question by John about the how we can use DSS to collect the MDG indicator. Because of some indicator in the MDG, they are mixed between the impact and outcome indicator, and also because when we talk about impact, the change is really, it's not just only 6 months or 1 year, maybe 7 years to measure it. So that's why we collect only some of the we call the proxy indicator for the MDG, like a skin birth attendant you have mentioned about, or maybe.
Okay, let's go through it. I mean, in your health information system, do you collect underweight children? There's no argument about that. No discussion. Yeah? You collect data about children dying. Do you? Yeah? Under 5, under 1. You collect data about, I mean, when you go through it in this kind of cold clinical fashion, it's a millennium death goals, huh? More than millennium development goals. But it's deaths of children under 5, under 1, women, deaths of malaria, deaths of TB, deaths of HIV, AIDS, huh? All of those deaths we collect at our health facility. If you don't, then there's something wrong. Yeah? This one, there's a lot of discussion about it. Huh? A lot of countries don't collect antenatal care, HIV status in that particular age group well. So that one is maybe one that is dubious. Measles immunization, do you collect it? Huh? Skilled attendance at delivery. You probably pretend that you do, but you cheat. Essential drugs availability. I mean, every country has got a different definition of what drugs are essential and what we mean by availability, so it's very difficult to measure. But, I mean, there are none of these, I think, that you can say are difficult to collect. The problem is how you collect them and exactly what your measurement is. I mean, have I answered your question? I mean, and I really think that you people, if you're out there designing your health information systems, if you're not including these Millennium Development Goals, you are failing your own people. You have to include these Millennium Development Goals, and you have to convince the policymakers to include them.
Okay, for this health-related MDG indicator, I haven't seen one important indicator. For example, adolescent birth rate. It's
not a Millennium Development Goal. I mean, it's very important. It would come just.
It's 5.4 development goal.
No.
5.4.
Okay, I mean, it's an. But you see, this is in your country, Indonesia, is it? Lao. It's very important. In many countries, it's very important. Yeah, but it's not part of the Millennium Development Goals.
It's related to maternal mortality.
Oh, it's a terrible. Most of these women dying are probably under 20 years of age. Huh? I mean, it's important, but what I'm presenting is the international picture. And countries are encouraged to include what is important for them. I mean, yours is only 5.4. In Tanzania, where I work, it's nearly 10% or 12%. Huh? And I mean, it's a disaster, all these small girls getting pregnant. And even it's under 15, there are 13-year-olds getting pregnant. I mean, it's a disaster. But it's not a Millennium Development Goal. Huh? All right? Include it in your national thing. But then if you're measuring adolescent pregnancy, you have to also measure ordinary 15 to 49, the full range getting. It's a subdivision. Huh? All right, let's move on a little bit. What we've dealt with in the Millennium Development Goals is the kind of high-flying systems management, huh? The stuff that's all a little bit up in the sky, covering the whole country, and a lot of it is kind of firefighting. It's right up there. But there are the other levels of management which I think are very important for us to include in our health information system, are indicators about facility management, because we've got thousands and thousands of facilities in our countries that the management could be vastly improved by the use of good information. Communications, transport, buildings, the environment, maintenance, making sure that you've got enough equipment, making sure you've got enough drugs, and dealing with the clients. There's a huge amount of management that at the moment is based on no information at all, or haphazard vertical transport systems or logistic management systems or equipment systems that are not integrated within one facility. You've got multiple different systems that are functioning in one facility. I see some nods coming from around the table, so I think people are understanding that. But I think it's absolutely crucial that we use the 21st century integrated information systems to manage our facilities. It's all very well managing the Millennium Development Goals, but we have to have integrated systems to manage our facilities. And DHIS provides a huge platform for that integrated management of activities. And certainly my experience is the more decentralized your system is, the more chance you've got of people being able to manage that. I mean, I've just been in Rwanda, which is a very poor, very small country. But if you go to the facility there, the officer in charge has got a budget, and when the roof starts leaking, he's able to go and call a local plumber to come and fix the roof. When he runs out of drugs, he's able to go and buy drugs at the local pharmacy. Other countries which are more centralized, like the one where I live, which is Tanzania, if your roof starts leaking, you have to sign a requisition form in triplicate to the provincial office, and maybe a month later somebody will come and inspect your roof to see that it's leaking and say, sorry, but now all your equipment is spoiled. You'll have to buy new equipment. You know, I mean, every system is different, but this integrated facility management is absolutely vital. But the other thing that is becoming increasingly possible with our DHIS is patient management. And I think today is Tracker Day, isn't it? In the end, the whole health system is about managing patients. You have to make sure that everybody, whether they're suffering from chicken flu or deliveries or having to have their teeth pulled out, are getting the best possible service. And our health information system in the past has not really concentrated on individual patient management. We've always dealt with aggregated patient data at a higher level. But increasingly, the DHIS is moving towards getting proper client management, not only at facility, but also in the community. And I think this is one of the things that is really revolutionizing our healthcare, is that we're able to use these magic mobile phones and get people in the community to manage clients in their own homes without going into the facility. So it makes your question about, how do we measure maternal mortality and the various mortality, the Millennium Development Goals, much easier. If your mobile phone system, your mobile data collection process is improving the management of individual clients, and we can collect data on that, on these individual clients. So this is a real DHIS with increasing computerization. We're moving down from this level to facility management and increasingly to client management. And I think this is a really important thing, because it's putting power and knowledge into the hands of people. Okay, John? We come back to our information cycle, and this, it's just as important for people to follow this cycle at facility level or even at community level as it is to follow the cycle at our level, at the systems level. I think I'm not going to go into that in more detail. How much time have I got? 15 minutes. Okay. The normal state of events is that we've got poor decision making, with everybody pulling in different directions, donors pushing this system, other donors pushing the other system, serious inertia and people not wanting to change, which leads to a weak demand for data, and most people don't trust the data that is being produced. We had a discussion last week here in Vietnam about ministers say, why should we invest in health information system? The data that you're producing is rubbish. With attitudes like that, what happens? You have weak health information system because there's not investment, there's no capacity to generate data, people are not trained to analyze the data, and so you have the system that is in most countries with the donors pushing their own little vertical systems and very little investment, and the cycle repeats itself. I'm sure all of you understand this, and that's why you are here. The biggest problem with that is a massive duplication of data. Each antenatal visit is recorded on 5 different places, going to 5 different donors, and the poor old health workers are swamped already. And then here comes the World Bank, and there's the Global Fund adding more data onto these poor, unfortunate health workers. John. Just going down, 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 down. Okay. Yeah. So I mean, I'm part of the donor blaming set, and I think that most of the problems in our health in our countries is to do with donors, because every single project, every single program has got its own data requirements. Uncle Sam and PEPFAR, are the worst. But they've all got separate plans, separate tunnel vision, and they focus on the indicators, but they don't provide any support to the overall system. And we need a change from that, John, where information is increased in availability. There are common goals and indicators, not just at international level, but at lower levels too, and coordinated investments in one health information system. It doesn't matter which health information system, and we're here because we're trying to convince you to use DHIS. But if you go away from this workshop and say, oh, I want to do ABCD7, it's not a problem. The issue is to get one information system for the country so that you don't have these various vertical programs, vertical information system. And people always say, how does HISP work? I mean, why is HISP so successful? Why is DHIS such a good system? It's not because it's very wonderful. It's just because the others are bloody awful. We have a saying that from when we started DHIS 2, in the land of the blind, one eye is king. If there's no information at all, then you give them a little bit of information and everybody's happy. So, and we see the HMIS as a catalyst for driving change, for driving real reform by telling people the truth. Very often, especially politicians at high level, they don't want to be told the truth. And if you start telling politicians the truth, there's blood on the walls. I've been thrown out of the Ministry of Health in many, many different countries for coming and saying, look, this is the situation, guys. This is what's happening. And they say, get out of here. We don't want to hear the truth. Out. 6 months later, they come back and they say, well, maybe what you were saying was right. Come back and, what was that program you were wanting to do now? Health information system, it is trying to tell politicians and managers the truth. Good, John? And what we're trying to do, it's not revolution, but we're trying to decentralize demand for information, to put power into the hands of local people through health sector reform, through sector-wide approaches to health, poverty reduction, use of IT, capacity development, using the media, using communication, and to try to increase the coordination so that America starts to talk to England and Germany. And HISP started in 1994 when Joran and I were working at university. I was at the so-called black university in South Africa. Joran was at the so-called white university in South Africa. And we developed the first ever collaborative project between these two universities in South Africa. And it's that coordination of activities that leads to improved health information systems through integration, interoperability, all the catchphrases that you've been using over the last few days. And a focus on building unified systems rather than individual silos, so that the systems respond to the needs of the country and especially to the needs of the local people. And then we have the global initiatives like DHIS2, which are stimulating at a higher level results-based decision-making. Okay, I think we're starting to run out of time, but there are a few key activities that need to be done before the HMIS starts working. One is you need clear guidelines on high-level integration, coordination, interoperability, that kind of stuff. But at the lower level, we need a focus, because to me, measuring these Millennium Development Goals is not something that can be done at the higher level. those of us who are old enough know the Alma Ata Declaration, with a district level focus, because that is where the community and the international levels meet. And we need a focus on local priorities, and as well as the international priorities. One of the things that DHIS is doing increasingly well is providing practical feedback to health staff. We're able to use the dashboard, use electronic communication to provide feedback to staff so that they can use information better for the decentralized management at those 3 levels I was talking about. John? Let's leave this good down. I think that's... we've got time? Yeah? Okay, up?
So the HIS Academy, we never runs out of time.
Oh, all right, fine. Okay, I mean, if we go through that cycle again, we need to focus a little bit on the individual components. And the key, the first thing for me is one data set, one indicator set. Unless you've got that, your health information system is designed for failure. If you've got multiple indicator sets, you've got multiple data collection processes, you've got chaos. Every data element that is collected must be understood by everybody who collects it, so that at the lowest level of the data collection chain, the village midwife, she must understand the difference between each of the things that you're asking them to collect. And I was, again, in Rwanda the other day. They had a list of 17 different conditions for maternal mortality to be collected by a village midwife. And I didn't know the difference between some of these things, so how they expected this poor village midwife to differentiate between a placenta previa and an antepartum hemorrhage, I do not know. But that was there. And so one of the temptations that we have to resist in designing our health information system, when it's so easy to collect all of this data, is to make to a minimum data set that everybody understands exactly what they are collecting, so because that's the basis of data quality. We need one set of forms, and we need, especially at the beginning, continuous support and supervision. I think that, again, I don't know how your countries work, but I think that the crucial element in all of this is to have one person at district level who is in charge of health information system and nothing else. In, again, Tanzania, where I'm working at the moment, you have one person in charge of the health information system, but at the same time he's the HIV/AIDS coordinator, at the same time he's the environmental health supervisor, at the same time he's something else. He's got 4 different jobs. There is one person in charge of health information, but it's not dedicated. So we need one dedicated person responsible in each district, and preferably at each facility. Yeah. In terms of data processing, again, when you're designing your system, it has to be clear exactly who is responsible for data entry. We have to have fixed dates for reporting. those kind of basic things are essential for people to be able to use data, because data that is 6 months out of date cannot be used. Data that is not complete cannot be used. It has to be in on time. There has to be a system in place for use at facility, and it needs money. I mean, you've got no idea how many countries you go there and you say, why aren't you doing this, or why aren't you doing that? Oh, we don't have money to pay the bus fare to send the data up to the next level. So we have to get resources for use at facility level. And there has to be local quality control. There has to be, the lower down the information pyramid that data quality is controlled, the better. And certainly from my experience, unless the facility manager takes responsibility for all data, you are not going to get good quality data. And unless you've got good quality data, there's no ways you can use it. So this data quality is absolutely essential. And then once it is computerized, then we need analysis at district level. Don't wait to analyze the data until it gets to you at head office level. Okay, presentation. I think you'll be hearing a lot about that. Regular feedback. Graphing using data visualizer, dashboards. I'm not going to tell you about that. Geographical information system is probably the most powerful tool that we've got, because then people can see their geographical area and see exactly where the problems are. And then I go back again to supervision and support, because it's absolutely at the core of any functional information use. Yeah? All right, this is, I think, the last slide, which is a kind of a summary of all of it. I'm afraid it's not very clear, but here, as the spinal cord, as the central pillar that is holding up the entire health information system, is a set of indicators. MDG indicators plus your national indicators. Those ones are translated into a variety of report forms for maternal health, for child health, for various diseases, for various priority programs. But the core to good information use is that all of those vertical programs come together at the lowest possible level, at facility level, into one integrated monthly report. Yeah? If you have this going to the malaria coordinator and that going to the schistosomiasis controller and another one going to the dengue fever devil, then you're going to have trouble. It has to all come into one integrated monthly report. That monthly report is put onto whatever the health management information system software is. We like to think that it will be DHIS2, but it doesn't matter. It has to be put into one central place where everybody can have access to it. That software produces a variety of outputs in the form of graphs, maps, reports, whatever, all the things that you're going to be taught how to do during this workshop. But then, if you stop here, it's just another a data collection process. What has to happen is that human beings sit down and work together and collaborate and share and try to understand what the problems are generated by this. And through a process of self-assessment, of ongoing monitoring, they're able to make informed decisions using this information that then feeds back into the process of collecting data. Because if these guys say, oh, we need information on teenage pregnancies, that must feed back through into the system and come out in that, I can't reach it, maternal health report, because you think that teenage pregnancy is important. He thinks that schistosomiasis is most important. That must go through that process, and it must be an agreed upon process of local level monitoring. Are we happy with that? Yeah? This is the ideal situation. This is what I have not touched on population data. Often a headache. We have to have good population data as the denominator in most of our indicators. There's a whole lot of stuff here on which we call, I think we still call it semi-permanent data, don't we? About the equipment that is available and the staff. It's changed, all right. It's now got a human name rather than semi-permanent data. Infrastructure data, human resources and equipment. There are other systems that are functioning at most places, and then also there are surveys. I mean, this is something which is often neglected because there are a lot of in-depth surveys that are done, university surveys, multiple indicator cluster surveys, demographic and health survey, and these are extremely useful for the triangulation of data to ensure that it is accurate. I mean, very interestingly, for example, in South Africa, they've just compared the demographic and health survey and the DHIS data in South Africa, and it's within 2% of each other for things like immunization. So that this argument that it is not possible to have routine data as accurate as survey data is becoming, once you've got a mature routine information system, the surveys are there, they're the gold standards, but our routine system, we can triangulate against them. Okay, that's the dream. I'm not going to talk about decision making, but there's an old English saying, you can take a horse to the water, but you can't make it drink. You can present people like yourselves, national level bureaucrats who are sitting in air-conditioned offices, present them with all the information in the world, but that does not mean that they are going to make correct decisions. There are all the political pressures, the pressures from the donors, the pressures of money, pressures from their own people, pressures from the community, every kind of pressure on decision makers not to use the information that you present them. All we can do is say, here is the information, this is as close as we can get to the truth. But that doesn't mean that anybody is going to actually do anything with the information that we give them. So the gap between information and decision making, I don't have to explain to you. You know how your own countries work. Next one. And I just come back to this very old slide. In fact, this information pyramid was something that Joran and I put onto our very first report ever, which was to advise the Minister of Health in South Africa in 1994 on how to strengthen the health information system for our local province. It's action, action, action. At local level, we can take local action. District level, it's about planning. At the higher level, it's about monitoring and evaluation. At the top level, it's about Millennium Development Goals. But the vast majority of the health information system is down here, and it's action, action, action. Thank you very much. All right. I didn't say anything that everybody understands everything perfectly.
And that's why you have a question right from here.
Just to go back to that vicious cycle which you just presented, not the HISP one, the other one.
Yeah. Yeah, talk.
Yeah, this one. No, the other one. No, not this one.
You want?
Exactly this one. So this is exactly relevant to from where we come from, but I'm not sure about other countries. But this is pretty much relevant to our context. Like we have a very big demand, and most of the things are driven by the donor, not the need base. Because coming from a country where we have not luxury of resources, we have to depend on the donor when they come with the money. So we'll have to go with their needs, not our needs. And then we have a big demand as well from the people in the health system. As long as they have the report ready at the end of the day through paper or through email or all, they are happy with it. So this vicious cycle is very much relevant. So how do we get out of this cycle? From where do we start? We have to break this cycle in order to get the HIMS running. So where do we start? How do we break out of this cycle? So this is what we are wondering.
Where you start depends on where you are. For me, the key to starting is to have something to show them. If people say, I don't know, I mean, you probably don't have a big HIV problem in your country, but whatever the priority problem is, what are the donors providing money for? Are they providing money for mother and child health, for immunization, for what? Use an integrated approach to provide them with useful information from the national system. As long, donors, there are many stupid donors, but most of them are not. They want results. And the reason why they're setting up health information systems of their own parallel ones are because the national health information system is not producing results. If you at national level can show, for example, the EPI program, that my data from my routine information system is just as good as your bloody UNICEF one, then why should UNICEF invest in their own parallel system? They will put money into your one. If Global Fund wants data on TB, show them that your data in your TB system is just as good as the data that is coming out of the TB. So data is not trusted or used. I mean, that's where it starts. And maybe I should be no data for policy making or reporting to Geneva and New York. Because that's the problem. If they want family planning data, show them that you've got family planning data. That's my approach. I don't know, anybody else got any other good ideas? But the reason why they invest in their own parallel systems is because the national system is not. And now with DHIS, you've got a system that can pull in their data and then spit it back to them. Huh?
For those countries that are struggling with getting donors to invest in their health system, a lot of the grants these days with Global Fund and Gavi have what we call a health system strengthening component, and it requires a separate application when you apply. I would encourage most of you guys to talk with whoever's helping you out with health systems in your country, how you can apply for that portion of the grant, because that is dedicated to things like investing in the health information system, etc. So it takes, sorry. So there's a component to a lot of grants these days called health system strengthening, and this is part of Gavi and Global Fund now as well. And I encourage a lot of you guys to apply for that in alignment with the kind of programmatic portion of those grants. This will help to get some of these donors investing in your actual health information system architecture rather than building their own kind of separate system. So we know we have a lot of parallel systems with donors, and they're pushing down their forms and their requirements and their reporting requirements to you guys, but you can apply for this health system strengthening component. There is a monitoring component as well to that, but it's all monitoring through your routine health information system, not something separate or disparate. So you might want to talk about that a little bit more when you get back to your country and speak to the person who's helping you manage those grants.
Yeah. But the trouble with that's great, but it takes 4 years or 5 years, and round 27 in 2019, you'll get that money. But in the meantime, there are short-term actions that you can take, and that is just give the donors what they want. Huh? And if you've got already a system that is functioning, then the Gavis and the global funds will be much more likely to give you that health HSS money. But to me, we have to take short-term approaches. That's a long-term building thing, but make sure that your national health information systems can provide the donor with good quality data. And that's to me the essential thing. And you know, God helps those who help themselves. And if you show that you're moving, then the donors will support you.
Jan, you wanted to say something? You're looking very curious. No. Yeah?
I think what the donor requires, I mean, annually we have annual health bulletin series. We just throw them as bulletin. It's all there, I mean, all the routine data and everything. So it suffices everything, I mean, what donor requires.
Yeah.
My question now is, like, the trust of routine data is, I mean, not very strong in the country. Like, some indicators we get are good, I mean, like antenatal care, these things are good. Where there's involvement, I mean, kind of like the live births, maternal deaths is very sensitive indicators. Even the under 5 days, infant mortality rate. Because unless you have, I mean, civil registration and vital stats is very strong in the country, the denominator is a big issue. We only collect, I mean, the institutional births or dates. And there are some underreported, which happens in the homes, which are never captured. So that thing makes, I mean, the trust on the routine data very vague, I mean, laced from the decision makers.
Yeah.
Anyway, we do use it, but unless the national level survey is being conducted, we don't, I mean, use it for the MDG schools, anyway, to measure the MDG schools. But somehow we calculate it as a routine data with the footnote saying it's, I mean, not nationally reported cases or something like, they are underreported cases. So how we build the trust, I mean, to make it.
Include some more questions to his question to Arthur is, and also a bit of answer. How do we use the survey data into the routine HMIs?
Especially MMR is very sensitive.
Yeah.
With 3 days, it shoots up. With less days, it goes down.
Same like Bhutan, Laos also, they just collect births at facility. So they don't really collect births. Yeah, so what we can do with that?
I mean, to me, the first step is to get this right. We have to get accurate data coming from our facility level. That's very easy and clear within our scope. And most countries don't even have this correct. Once we've got that, a process going for that, we can start looking at these other systems here. The community health worker, I think this mobile phone revolution, I don't know how much you've talked about it today, but that's a real revolution that's happened in the last 5 years. And that, if that is strengthened, that gives you enormous power to improve the community-based stuff. It enables you to get much better population-based data and to even correlate but if we have a community-based system that is going parallel, that goes out here somewhere to another system, then we're asking for trouble. It has to be an integrated HMIS that is collecting data. And these surveys, if we've got a, maternal mortality ratio of 500 in the country, and the facility-based one is showing 300, then we know that we've got that gap. Then we know where the problem is. And we can use community-based reporting. We can strengthen the the demographic, the births and deaths reporting, the civil registration, strengthen the civil registration system. There are all sorts of things, but at least we've got 300 out of the 500 deaths being reported. That's a good start. Then we know where we are. If we don't have that data coming from here, then we don't know where we are. I think that's, everything starts with the first step. And once you've taken that first step, the next steps become until we're running and we're able to satisfy the Gavis. I don't know. That's my, start small and increase, but with a focus.
One other thing is just don't compare that data to the surveys. And most of the time, the decision makers, they always say, routine HMIS is bad when you compare your infant mortality rate from your facility and from your surveys. You can compare the immunization, the ANC coverage, all the things are quite fine because those are coming through the health system. But when you're doing with deaths and things, it's always true. Civil registration is in different departments, different ministry. And it's the health, we are having births and deaths, but that also very different. So when you compare with the surveys, and if you want to convince your national people, choose the data or indicator which you are more confident. It's yes, we are working on this one because there are also other graphs. It's not only about the births are reported, but there is also most of the people underreported, because if they report it, and then the people at the top level say why did you report it? You should not report infant deaths. And so there are also this other kind of thoughts behind it or institutions behind it. Arthur, you want to add something?
No, I think I've talked enough. But you guys are all focusing on this. Remember that there's a lot more to getting a strong information system than just a computer. There's all of this indicators and all the systems of getting that data up into the computer. And once it's gone out of the computer, unless you have this team approach to using the information, just collecting the data is not good enough. That's probably my last thing to say. Thank you very much, and enjoy the rest of your workshop.